Ovarian cancer is the most deadly among gynecological malignancies. Every year, 400,000 new cases are diagnosed across the world, and 300,000 patients die every year for this tumor. And unfortunately, the situation is quite unchanged in the last 20 years. The problem of so high aggressivity is related to the absence of any screening for this tumor, and also to the symptoms which are not typical of ovarian cancer, but more typical of other bowel and more frequent disease. For all this reason, in most part of cases, more than 80% of patients with diagnosed ovarian cancer is stage 3 and 4, and this greatly impacts on our possibility to cure our patient. When the diagnosis is done, we have primary surgery, primary chemotherapy, but unfortunately for most of our patients, more than 80% of them, the disease occurs again and will recur during the first 3 years. This is the reason why we spend the last 10 years of our clinical research in trying to identify a so-called maintenance treatment. I mean something which is not chemotherapy, which does not have the side effect of chemotherapy, but can contribute to maintain disease under control after chemotherapy completion. In this scenario, there is no doubt that PARP inhibitors play a major role in the setting of maintenance treatment. The great success of this new class of agent was testified by the last 6 years. PARP inhibitor obtained approval in second-line and also in first-line setting, and they greatly changed the natural history of ovarian cancer, more than any other class of agent. And looking at the SIR database, which clearly reported a decrease in incidence and mortality of ovarian cancer, this decrease in mortality is related only to the advent of PARP inhibitor in our clinical practice in the last 10 years. One of the most important trials evaluating the role of PARP inhibitor in ovarian cancer was PRIMA trial. PRIMA trial enrolled the stage 3-4 high-grade serous and endometrioid ovarian cancer patients newly diagnosed will receive carboplatin paclitaxel chemotherapy for 6 cycles. If patients achieve a complete or partial response to chemo, they were randomized to receive PARP inhibitor niraparib for 3 years of placebo. Of note, the patients enrolled in PRIMA trial were the worst prognostic population patient we treat in our clinical practice. All stage 3 patients, in order to be enrolled, has to have residual tumor. 70% of patients received new adjuvant chemotherapy, 30% of patients were stage 4 tumor, 30% of patients start treatment with evidence of disease. So this was a very bad prognostic population, but high responsive to platinum, because in order to achieve the trial, CA 125 should be negative. This means that these patients were selected because they were high responsive to platinum. The trial clearly reported an advantage of 3 years maintenance with niraparib with respect to placebo. The advantage was huge in BRCA mutant, very high in HRD BRCA wild-type patient, but also HRP patient reported the advantage in terms of reduction in the risk of progression. And very interesting to me, the advantage was confirmed at a longer follow-up. After 3.5-year follow-up, the reduction in the risk of progression was 48% for HR deficient patient, but still 35% for HR proficient patient, thus suggesting a long-term benefit of maintenance treatment with niraparib in ovarian cancer. When we used the niraparib in PRIMA at the beginning, we used the full dose of 300 milligram once daily for our patient. But in the meantime, we received the data of the radar analysis in second line NOVA trial, suggesting that patient with a body weight less than 77 kilo and patient with a number of platelets less than 150,000 should receive 200 milligram. So we amended the protocol and we enrolled a group of patients with received treatment at the individualized starting dose according to body weight and platelet. And it was evident in the trial that if we adapted the dose to body weight and platelet number, we achieve the same control of disease, but a great improved toxicity profile, particularly in terms of hematological toxicity, mainly thrombocytopenia, but also non-hematological toxicity. So it's quite clear now that we have to use the individualized dose for our patients. And now we have enough data, retrospective but also prospective data, suggesting that the individualized dose greatly improved the toxicity profile of the drug, but does not impact on the efficacy. Also recently, a few days ago, during the SGO in Tampa, they were presented the results of PRIME trial, the same of PRIMA but in a Chinese population, further confirming that the individualized dose does not impact on the efficacy of the drug. So we can be confident that when our patient has any kind of side effect, we can further reduce the dose and we can be quite confident that this does not impact on the efficacy of treatment. The individualized dose reduces greatly toxicity, but does not preclude and does not avoid the full monitoring of our patient. It's evident in the trial that most of the toxicity occurring during the first 2 or 3 months of treatment. And this is the period in which we need to carefully monitoring our patient. It is suggested to perform weekly blood exams for the first 2 months of treatment, and if no toxicity occurs, we can move to the monthly monitoring. But it is of utmost importance to carefully evaluate the first 3 to 4 months of treatment, because if a toxicity occurs, this is the period in which it can happen, so you need to adapt the dose and continue treatment. It's much more important for the patient to have continuity in treatment than to maintain the full dose. We have a lot of PARP inhibitor. We do not see particularly difference in terms of efficacy, but what is important sometimes is to choose the best drug for the patient we are treating. And from this point of view, niraparib has some advantage. The individualized dose is only for niraparib. All the other PARP inhibitors did not identify different dosage according to the characteristic of the patient. Niraparib has another advantage, the one daily administration. PARP inhibitor can have nausea in more than 70% of patients. For sure, it's a grade 1 nausea, does not impact in daily living, but it can be tricky for the patient. The one daily dosing offers the possibility to take the pills before going to bed, and this helps a lot in managing nausea. Another great advantage of niraparib with respect to other PARP inhibitors is the limited drug-to-drug interaction, which is a great advantage because our patient takes a lot of medication, they have several comorbidities, so the possibility to have a PARP inhibitor that does not impact on the liver metabolism of the drug is a great advantage because there is no drug-to-drug interaction. I think that we are very lucky because we are living an unprecedented moment in the treatment of ovarian cancer. The knowledge, the biological knowledge of tumor, which clearly identified that 25% of patients present BRCA mutation and an additional 25% of patients present other mutation of other genes also involved in homologous recombination give us a clear message. This patient, both BRCA and HRD, should receive PARP inhibitor, and they should receive PARP inhibitor in first line, because yes, for sure, we can use PARP inhibitor also at the time of progression, but first line is our place to cure the patient, and we have to offer the patient the best we have. So I have no doubt that HRD patients should receive PARP inhibitor in first line. We have also an alternative also for HRP patient that I would love to call HRD negative test patient. We can offer also in this population PARP inhibitor, particularly in patients who have achieved a great response to platinum with very fast decrease in CA-125. All these signals suggest that this patient, regardless the name they receive by the test, are high sensitive to platinum, and these are the best candidates to PARP inhibitor in first line.